Hi, good morning. This is Dr. Jessica Spies from CTA Pathology, one of the dermatopathologists on staff here, and I'm continuing the resident lectures based on the Lever Histopathology of the Skin textbook. And today is going to be unknowns, covering in part the last few chapters of Lever that my colleagues covered this last month: viruses, protozoa, and the histiocytoses. So since we didn't have a large number of cases in our study set for those three chapters, I'm going to go over a few unknowns, and then I'm going to show you some interesting cases from my last couple weeks of practice. So let's dive right in here. This first case was a very extensive eruption. Actually, I've got clinical photos and a patient here that actually came in as an H&E biopsy and a DIF, specimen for DIF, and you can see that's this vesicular eruption here, more erythematous, but also vesicular. In an older patient. And here is the H&E biopsy. You can see at low power that we've got an intraepidermal vesicle, really impressive vesiculation. And we've got a little bit left of the lower half of the epidermis clinging to the dermis here. Let's go a little bit higher, and you might think this is an immunobullous disease at low power. We've got quite a bit of acantholysis, making you think if this is an immunobullous disease, could this be pemphigus? But if you look a little bit more closely, you can see that these cells look a little funny. And if you look at high power, you can see that they don't look like normal keratinocytes. Their nuclei are often multinucleate, and they have these inclusions in their chromatin. They've got these slate gray nuclei. Here's a great multinucleate cell, and you can see that some of these nuclei are molding together. So this is herpes. It's either herpes simplex or herpes zoster. You cannot distinguish between the two based on histology alone. And in this case, I asked the clinician, would he like me to do immunostains to differentiate them? And he said, yes, please. Here is the immunostain for herpes simplex 1 and 2. And you can see it's a red chromogen. You can see that it's completely negative in these cells. And here's the herpes zoster immunostain. And bingo, this is an atypical presentation of herpes zoster. Really beautiful. Actually, we're going to keep this tissue for our control. You know, usually such a great specimen. Okay. Sorry, let's go to the next case. And this was a lesion on the lower leg of an older male that was a violaceous. The biopsy was to rule out non-melanoma skin cancer or melanoma or something else atypical. And you can see here we have a nice big broad shaped biopsy. And not much is going on in the epidermis at low power, but you can see here there is something going on in the dermis. And we've got this proliferation of spindled cells, some inflammatory cells, these cells with the dark nuclei and not very much cytoplasm or lymphocytes. This kind of kidney bean shaped nucleus with the small nucleolus is a histiocyte. And then we've got lots of vascular channels you can see here. Some extravasated red blood cells. And then these pigmented cells, these are siderophages. This kind of golden globular refractile pigment is hemosiderin. Sometimes it's difficult to differentiate from melanin. You can do a Pearl's iron stain, and that should light up the hemosiderin in the siderophages. So what's going on here? So we have, it almost looks multinodular here, proliferation of thin-walled vessels with inflammatory cells, red blood cells, siderophages. You could think that this would be an inflamed hemangioma. Why would I show you this covering the virus, protozoa, and histiocytosis chapter? Let's look out here towards the edge of this lesion, and you can see there are many spindled cells. Not all of them are histiocytes. And here at the edge we have, this is the patient's probably normal papillary dermal vessel. And around this vessel we have these new vascular channels. This is called the promontory sign. You don't always see this, but when you see it, this is pretty much pathognomonic of Kaposi's sarcoma. When I trained back in the 90s, they had just discovered that HHV8 caused Kaposi's sarcoma. At that time, we didn't have an immunostain for HHV8, but now we do. And so that will clinch the diagnosis. And here is the, let's see, HHV8 stain. And HHV8, the HHV8 immunostain will often just focally stain Kaposi sarcoma. This actually stain, this particular instance, we have a lot of staining. And you can pick out, this is a brown stain. Lots of these spindled cells picking up the stain. And you can, let's go over to some of these areas where there are actual vessels with the endothelium staining. So that's a positive HHV8. HHV8 is a human herpes virus, first discovered in patients with Kaposi's in the AIDS epidemic, as I said, back in the 90s, 80s and 90s. The endothelial cells infected with HHV8 undergo altered lymphatic differentiation and manufacture cytokines, creating a favorable milieu for angiogenesis. And I think that's all I wanted to say about this case. Really, great pickup on the pathologist's part, because the clinician did not suspect it. And by the way, in not just HIV-associated Kaposi's, but all of the forms of Kaposi's are associated with HHV8. All right, let's go to the next case. All right, so nice big shave biopsy cut into about 10 pieces. And we can see at low power that the epidermis shows verrucous or papillated epidermal hyperplasia. And the epidermis at low power is really blue. There is hyperkeratosis with parakeratosis. And if we look more closely at the epidermis, we can see there has a very blue and kind of jumbled appearance. And if I had normal epidermis to show to you, I would, but I believe that the entire biopsy is taken up by this lesion. This is full thickness squamous atypia. You can see this is a tripolar mitotic figure, and there should be mitotic figures above the basal layer. And also important to the diagnosis are these individually apoptotic keratinocytes. This is squamous cell carcinoma in situ, but this is on the genitalia. So this is an HPV-induced squamous cell in situ or boinoid papulosis. If this case had gone to general surgical pathology, this would be called vulvar intraepithelial neoplasia, grade 3, or if it was on the penis, penile intraepithelial neoplasia, grade 3. This is associated with the high-risk subtypes of human papillomavirus infection, most commonly HPV types 16, 18, 31, 33, and 51. And we now have commercially available antibodies to identify the low and high risk HPV virus subtypes associated with cervical dysplasia and neoplasia. And so we can perform those on skin biopsies. There are many, many more types of HPV than are that occur in the skin than are looked for in that assay. So if you're just looking for HPV types in a kind of a run-of-the-mill wart, we really don't have any commercially available antibodies to look for those. And I think that's all I wanted to say about this case. Moving on. Next case. So we have a smaller shave biopsy than the last case. And you can see we've got this crateriform lesion, like a little volcanic crater, with epidermal acanthosis and a lot of pink at low power, kind of a purpley pink color. And these are intracytoplasmic inclusions in the keratinocytes, pushing aside the nucleus. You can see here it's pushed to the side of the cell, and most of the cell is made up of these cytoplasmic inclusions. And as many of you have guessed already, this is molluscum, a pox virus, and pretty much nothing else looks like this. In dermatopathology, this is a low power diagnosis for the most part. So that's cute. The pox virus is called molluscum contagiosum pox virus. Next case. Okay, so here we have a kind of a thick shave biopsy. You can see there's a little bit of parakeratosis here, a little bit of acanthosis, maybe some spongiosis, but most of the action is in the dermis. The other half of the shave biopsy, there's a very sharply demarcated epidermal, full thickness epidermal ulcer. Lots of fibrin, degenerating inflammatory cells. And here we can see at this power, lots and lots of eosinophils. These are the cells with the brightly eosinophilic granules and bilobed nuclei. There's some extravasated red blood cells. Those are the more refractile looking, kind of not as deeply eosinophilic staining. And then if you look at the infiltrate, you can kind of imagine that it has an inverted wedge shape here if we had the whole biopsy. Pretty dense lymphocytes with these small nuclei, condensed chromatin, very blue, not very much cytoplasm. Histiocytes, these are the cells with the often kidney bean shape with a small nucleolus. We maybe have a plasma cell here, many eosinophils still. And this is an arthropod bite reaction. And most arthropod bite reactions contain eosinophils, but not all. Mosquito and flea bites may show mainly neutrophils. A drug eruption can have this histologic appearance if it's been scratched. This is a punctum, but this could also be the long painted fingernail of somebody scratching. Persistent arthropod bite reactions, and this one is getting pretty cellular, can have a pseudolymphomatous look histologically to them. And you have to be careful when you look on high power. There can be large activated lymphocytes in these, which will be CD30 positive. And that does not mean that it's a CD30 positive lymphoproliferative disorder, such as lymphomatoid papulosis. However, there's quite a bit of histologic overlap in arthropod bite reactions and lymphomatoid papulosis, since they can both have large CD30 positive lymphocytes. All right, let's go into the next case. I want to show you the second slide in this. All right, so at low power, we've got a pretty deep punch biopsy with some subcutis. And then we've got a follicle here with this large collection of mostly neutrophils within it. Here are the neutrophils percolating through the follicular epithelium, lots of neutrophils in the surrounding dermis, also lymphocytes, histiocytes. There are probably also some eosinophils in here. And then what is going on here? This is the hair shaft of this follicle, and you can see all these blue dots around the hair follicle, and these wiggly, clear forms within the hair shaft. I'm sorry, hair shaft is what I meant. Let's go. Here you can see that the follicle's been ruptured. There's just this naked hair shaft left, surrounded by this dense neutrophilic infiltrate. Well, with all of these blue forms, and then these within the hair shaft, these kind of wiggly clear forms. This is dermatophyte infection with a separative folliculitis or myakis. When you have the dermatophytes surrounding the hair shaft, that's ectothrix. When you have them within the hair shaft, that's endothrix. And what did I want to say? What else about this case? Actually, this was in our study set as tinea capitis. And in the United States, tinea capitis is mostly caused by Trichophyton tonsurans, which is an anthropophilic dermatophyte, meaning it is human-to-human transmission, excuse me. Actually, different dermatophytes are more common in tinea capitis in Europe. Following invasion of the keratinized stratum corneum of the scalp, the fungus grows downwards into the hair follicle and into the hair shaft. All right, let's go to the next case. And we could see the dermatophyte in that case pretty well because there were so many of them. But sometimes they can be difficult to find, and I've done step level sections through the tissue block with H&E and PAS stains to find the dermatophytes in myakis before, and that works pretty well because they're often not in the initial level sections. And sometimes there are very few organisms. Okay, so next case. We can see again here, nice big punch biopsy, not very much epidermal change. All the action is in the dermis. And you can see it looks very blue at low power, whatever this process is. And let's go on higher power. We have an infiltrate of cells with not very much cytoplasm. They have a really high nuclear to cytoplasmic ratio. The nuclei are fairly pleomorphic, and they have what we call this salt and pepper chromatin, small nucleoli, and this kind of granular blue chromatin. And they're not sticking together very well, these cells. Not really making what you could maybe call these nests, more like aggregates. So you would think maybe about a lymphoma because that's not an epithelial neoplasm that makes nests. You can think about basal cell carcinoma maybe, a blue cell infiltrate, but we're not really seeing the nest with the peripheral palisading, the clefting between the nests and the fibromyxoid stroma. Some of you have probably already guessed the diagnosis here, but really the key to this diagnosis is the chromatin of these cells, the salt and pepper chromatin. This is a neuroendocrine carcinoma or Merkel cell carcinoma if it's primary to the skin. And the vast majority of primary Merkel cell carcinomas are cytokeratin 20. Here's a cytokeratin 20. And it typically has this dot-like paranuclear pattern. So you can see these dots next to the nuclei, which are not staining here. You want to prove that it's neuroendocrine in addition to the cytokeratin 20 when you sign these cases out. And here's the neurofilament, which is the most sensitive neuroendocrine marker. And you can see it has a similar staining pattern to the cytokeratin 20 with these dot-like paranuclear staining. When you get cytokeratin 20 staining, that's basically diagnostic of primary Merkel cell carcinoma of the skin and essentially excludes a metastasis from a visceral neuroendocrine carcinoma. Merkel cell carcinoma is associated with Merkel cell polyomavirus, which is one of 14 known human polyomaviruses, most of which do not cause illness in immunocompetent hosts. Merkel cell polyomavirus is the only polyomavirus associated with cancer that we know of. The virus DNA is found integrated into tumor cell DNA, supporting the role of the virus in tumor genesis in this disease, similar to what happens with human papillomavirus and cervical cancer. However, unlike in HPV and cervical cancer, Merkel cell polyomavirus integrating into the DNA and causing Merkel cell carcinoma is an extremely rare event, which does not appear to happen in most infections. Most infections are completely asymptomatic in immunocompetent hosts. Approximately 80% of Merkel cell carcinomas contain Merkel cell polyomavirus, probably more than that, but that's what's been shown in the literature. Okay, so let's move on to some interesting cases from my practice the last few weeks. I had some good ones. Okay, so here we have a shade biopsy of skin with something in the dermis that looks very blue, but different from what we saw in the last case. You can see there's this almost diffuse infiltrate of cells with pretty pleomorphic nuclei, lots of pink cytoplasm. Some of the cells have cytoplasmic pigment, which I can tell you is melanin. And if we look through this, it's a little bit asymmetric. There look to be maybe a few small nests at the epidermal junction. But really, this tumor is not very well organized. I thought this was melanocytic because of these nests. And also the appearance of the cells, very nevus-like. Many have intranuclear inclusions. But really, it's not looking like a typical nevus with nests and cells that get smaller, descend into the dermis that kind of this streaming look. They're not necessarily maturing here. And I thought, gosh, could this be intradermal melanoma? But I also thought because some of these cells are quite large and epithelioid, here is an epithelioid cell with lots of pink cytoplasm. The nucleus has, actually this has two nuclei. This one has a very prominent nucleolus. Could this be a BAP1 deficient nevus? So I did a BAP stain. And at low power, it kind of looks like, well, maybe the tumor cells are staining for BAP1. But what we look for is, for BAP1 deficient nevus, is loss of BAP1 expression in the nucleus, and that's what we have. The nucleus is not staining. We have a little bit of cytoplasmic staining here. So we've got BAP1 loss. And this is really good for BAP1 deficient nevus. BAP1 is a tumor suppressor gene associated with a cancer syndrome, first described in 2011 in a set of European families who had very ordinary looking nevi clinically, but on biopsy had these funny looking and often very bizarre appearing nevi with spitzoid melanocytes. So they were bizarre appearing on histology, very bland looking clinically. Most of these are benign lesions despite the odd cytology. And the vast majority of these BAP1 deficient nevi we've discovered in the subsequent years are sporadic in nature. Very few of them are actually in patients with germline BAP1 mutations. But if you do have a BAP1 germline mutation, this leads to a higher incidence of malignant mesothelioma, uveal melanoma, renal cell carcinoma, and cutaneous melanoma, 4 tumors. Actually, they're the 4 main cancers associated with the cancer syndrome, but there are actually more that have been described. The incidence in the general population is not known, and so far less than 100 families with the germline mutation have been identified. We actually do have 1 or 2 in Oregon here. And I would just say that the biologic potential of these tumors is still being worked out. Although the vast majority behave in a benign fashion, there are rare reports of transformation of BAP1 inactivated melanocytic tumors going on to behave as melanomas. So the current WHO terminology classifies these on a spectrum, with the lesions such as these with mostly nevoid looking cells and minimal atypia as BAP1 inactivated nevi, and those with larger numbers of these big epithelioid or spitzoid looking cells as BAP1 inactivated melanocytomas. Melanocytoma meaning we don't really know how this is going to behave, but we can't call it melanoma. And I would just say also there's very little known about the natural history of BAP1 inactivated melanocytic tumors or the phenotypic or histologic features of the primary cutaneous melanomas in this cohort in the patients with the germline mutations. And despite the high lesion counts in these patients with BAP1 inactivated melanocytic tumors, there's a very low rate of cutaneous melanoma. So we're still working out why that is. Really fascinating. All right, let's go on to the next case. All right, so here's a biopsy from the external auditory canal, and it came in pretty fragmented. You can see the clinician got quite a bit of tissue. This is all inflammatory. Scale crust with bacterial colonies, so it was impetiginized. Here's the underlying shave biopsy. And you can see there's quite a bit of solar elastosis. And this, in the epidermis, it has the boy-girl sign, the pink and blue sign, which is pink epidermis with overlying pink parakeratosis, sparing the follicle, which is blue, and the follicular, the basket weave stratum corneum over the follicle. These correspond to each other. So this is the pink, blue, and here we have a little bit of pink actually also. This is a clue to actinic keratosis. And actinic keratosis can have this budding pattern. We call that a hyperplastic pattern colloquially. You can see there isn't full thickness atypia here. We kind of have a hyperchromatic jumbled basal layer, but then the cells turn over on their sides and mature as they ascend to the granular layer of the epidermis. So we have an actinic keratosis in this part of the biopsy. And then what is this? Is this more inflammatory scale crust? Some of this is, but what are these cells here? These very dark, this may even be more than one nuclei here. And here's a bit of this tumor underlying this inflammatory scale crust. You can see really pleomorphic, bizarre looking cells. Some of them with some pink cytoplasm, some of them looking spindled in appearance, many with multinucleation. And then in this very last piece, here we have what looks a little more like ordinary squamous cell carcinoma. The cells are pleomorphic, but not as bizarre as those in the last piece. And you can see some of these large cells, but it looks more like a conventional squamous cell carcinoma, making nests and cords of cells. So what is this? Is this a poorly differentiated squamous cell carcinoma over here? Is this a collision of a squamous cell carcinoma and an AFX? Or is this a sarcomatoid melanoma? So we do immunostains. I actually did only one immunostain to start off with, and that was a cytokeratin 5/6. And you can see here, here's the squamous cell carcinoma staining very nicely. And here is that more sarcomatoid area, and the cells are also picking up the stain. So this is sarcomatoid or poorly differentiated squamous cell carcinoma. All right, next case. This is something that I had actually never seen before. And my colleagues, Jessica Gaffari and Brian Shapiro, had both seen a case of this. And so I, of course, had to show it to you all because it's a very rare and under-recognized entity in clinically and histologically. So this, as you can see, is a big skin excision to include quite a bit of subcutis. And here at the junction of the dermis and the subcutis, we have all of this hemorrhage and basically wall-to-wall neutrophils. So this is an abscess. You can see here at the edge of the abscess, we've got lots of histiocytes trying to wall it off. And then in the middle of this, we have this kind of bluish material, which doesn't really look like anything that I'd seen before. I thought it was just maybe some grunge artifact, you know, doesn't really look like talc, doesn't really look like any infectious organism that I've ever seen before. And there's even more of this in the next, I'm actually looking for this here. In the rest of this excision, more of this abscess, and then this more of this material, which has more of a distinctive look in this field. And this is a polymer or hydrophilic polymer coating embolism. This is a very rare phenomenon, first recognized in 2009. These are the hydrophilic polymers used to coat intravascular devices to reduce friction between the device and the vessel wall. And they can strip off those devices and run free through the vascular system. We actually don't see it in a vessel here. We see it out in the tissue in an abscess. The coating can, as I said, peel off the device, embolize to vital organs, cerebral and cardiac vasculature, and peripheral vasculature, which is what we have here. In this particular case, the patient had had a transaortic valve replacement about 6 months ago and first developed an abscess at the right groin catheter site. That was treated with antibiotics empirically. Subsequently, she developed similar lesions on the abdomen and the thigh distal from that original site, the original catheter site, and they thought it was infectious. They cultured it to no avail. They biopsied it, looked infectious. It was a big abscess, and then 6 months later, she develops. Oh, I'm sorry. This is one of the 6 month later lesions. Uh, uh, we actually get a biopsy with the polymer coating in it. So I actually did not recognize what this was, but Jessica and Brian did. So there are a couple of reviews in the literature on this. If you want to read up about it, it's really, really interesting and something to know about. Okay. Next case, another very, very rare phenomenon. Something that we're asked to rule out quite a bit, but we almost never see. And you can see lots of arrows in the, this was my case. I like to use the arrows and the circles. These were stellate ulcers on the lower extremities of a patient with end-stage renal disease. And the differential diagnosis was infection, calciphylaxis, pyoderma gangrenosum, maybe. I can't remember all of the things in the differential diagnosis. And we can see here at low power, we've got not much going on in the dermis, maybe a little bit of inflammation, quite a bit of subcutis. This is what you want to see to catch this disease. Not a lot of inflammation in the subcutis. You do have some fat necrosis, these pinker areas. You can see these are adipocytes dying, and then there's a little bit of fibrosis. And then we have foci of calcification. And it's difficult to tell if this one is in a small vessel or just in an adipocyte. Here is more calcification. This chatter is from when the blade hits it, when we're cutting, the histotechs are cutting the slide. More calcification. These don't look like they're in vessels. More calcification. This one might be in a vessel. You can see here is the thin-walled vessel with some red blood cells coursing this way. So I think this is probably calcification in a vessel, small vessel wall. And here's another nice example. I think this is also vessel wall with these spindled cells here and calcification. This is calciphylaxis. So what you want to see for calciphylaxis is calcium in the vessel walls, fat necrosis, and you want to see fibrin thrombi, which I believe we have in, because the clinician did a great job of digging out more tissue in this patient. You can see actually this is subcutis and it has a very pink appearance. This is ischemic necrosis. And here are vessels that are dying. And I think these are fibrin thrombi. And there may even be some calcification in here. So this is a really beautiful example of calciphylaxis. It's in the usual clinical setting for it. It can be very difficult to diagnose histologically. First of all, there's sampling error. You have to get quite a bit of subcutaneous fat, which is where the pathology is going to be. And there is a paper written by Jeff North at UCSF a few years ago describing the use of von Casa calcium stain, looking for the calcifications because they can be quite fine in vessel walls, not coarse, as we saw in this case where they were more obvious. You can see them at low power even. And that can be really useful in subtle cases to use the von Casa stain. The cause of calciphylaxis is not properly understood. We think that the primary event is occlusion of the small blood vessels in the skin by thrombus, skin and subcutis, which results in the spreading ischemia and skin necrosis. But it is thought that the clots occur because of the calcification. It occurs mainly in patients with end-stage renal disease who have secondary hyperparathyroidism, resulting in increased blood calcium levels, although it can also occur in patients with normal kidney function in the presence of hypercoagulability states. And actually, my colleague Jim Ramirez had a case of calciphylaxis this week. So we have 2 in a month, which is amazing. And in his patient did not have end-stage renal disease. His patient was on warfarin. Okay, let's go to the next case. Okay, so this was on the trunk of an older woman. And you can see here it's melanocytic at low power. These nests of melanocytes, some quite large, some smaller, and also single cells kind of percolating through the epidermis here between the nests. And then we also have some dermal melanocytes, small nests of dermal melanocytes here. It looks like it maybe ends in a nest over here on this side. You could say that it is relatively symmetric. But these large nests really bothered me at low power. And you can see that they're almost eating up the whole of the epidermis. That's called epidermal consumption. But actually, the nest has to go all the way to the granular layer to really call it properly epidermal consumption. But large nests in an older patient, you should think, could this be melanoma? And when you see those at low power, you want to look in between the nests over the suprapapillary plates for single melanocytes, which we have here. These are the cells with this gray cytoplasm. Now the cells with the little melanin hats, those are the keratinocytes in between the melanocytes. And you can show this up very nicely on a SOX stain. You could also use a melanase stain or HMB45, your melanocytic IHC of choice. Most people use SOX10 these days. And actually, I didn't do a SOX10 because I thought I really could see the melanocytes really well in this case. I thought, could this be a nested melanoma? So I'm showing this case because I want to talk about PRAME. And PRAME is a new antibody that we're using in our lab that stands for Preferentially Expressed Antigen in Melanoma. It's an acronym. And it's a melanoma-associated antigen that was isolated by autologous T cells in a melanoma patient at Memorial Sloan Kettering. It was recently introduced to the dermatopathology community by Klaus Bussam, who's the dermatopathologist at MSK. And the way that it's used is you determine positivity by the number of nuclei staining in the melanocytic lesion. So it's graded based on the number of nuclei. And you can see here in our tumor that we have almost every nucleus staining with PRAME. The intensity of the staining doesn't matter so much as the number of nuclei. And you can see here, even the nests in the dermis are staining with PRAME. So I showed this case around. I thought that this was probably a very sneaky, mostly nested melanoma. And we could not come to a consensus in our practice. Other people thought, this PRAME stain, it's new. I'm not sure I totally trust it yet. It really looks like an atypical nevus at first glance. So we were kind of divided between atypical nevus and melanoma. So we decided to send it to Phil Lebois at UCSF, and he suggested that we do a P16 stain. And as many of you know probably already, P16, here's the P16 stain. P16 is a tumor suppressor protein encoded by the CDKN2A gene located on chromosome 9p21. And if you have diffuse loss of P16 expression in melanocytic tumor, it's a very worrisome feature and can be used to support a diagnosis of melanoma. So here we have our tumor. Let's see if the control is actually on this slide here. Yeah, so here is what you would see in a totally benign melanocytic nevus P16 staining. It stains the nucleus and cytoplasm. And most of the cells in this tumor are positive for P16. That's a benign pattern. In our tumor, excuse me, get back to where I was. Where's my P16? Oh, that's because I'm on the slide, sorry. In our tumor, you can see that most of the cells are negative. There are a few melanocytes that are staining here in the background, but these are probably the patient's background non-neoplastic melanocytes. And even in the, let's see if we have a little bit of the dermal nests here, these are also not staining. So Phil thought that was really good for melanoma, and this was signed out as a melanoma, and I cannot remember the thickness. This looks like about 0.4. This is the cool thing about digital pathology. You can measure the tumor very accurately here digitally. Yeah, so about 0.4. All right, that was a great case. Next case. Let's see. Okay, so here we have a punch biopsy of skin. Has a little bit of that cookie cutter look like you see in morphia because there's so much dermal sclerosis. And we have not much going on in the epidermis, but we have this diffuse dermal infiltrate of these cells with pretty pleomorphic nuclei, making these ribbons or cords of cells, sometimes nest-like aggregates. Some of them are making little duct-like structures. And this, I was trying to find the cells within lymphatics because this is a nodule on the chest of a patient with a history of breast cancer. And so this is metastatic breast cancer. You can see in some places we have the nice Indian file growth pattern. It does happen in other tumors. Other things you might think about in this is metastatic melanoma, of course. And you can differentiate these with immunostains. You use a SOX10 or melanA for melanoma and a cytokeratin for a carcinoma. And one thing I do want to mention in this case is you never want to sign out something as metastatic breast cancer in a patient that doesn't have a history of metastatic breast cancer, because primary eccrine carcinoma of the skin can look exactly the same. And eccrine carcinoma of the skin and breast cancer are both carcinomas of secretory glands. And so they cannot be distinguished on histology or immunohistochemistry. There are some immunohistochemical panels which can help favor one or the other, but even the hormone receptors do not distinguish between those two diseases. So it was very nice. I actually had 2 punch biopsies on the same patient. And I had the nice history of this patient had actually had breast cancer recently. So I felt comfortable calling this metastatic breast cancer to the skin. Okay, next case. Huh. Okay. So here we have a punch biopsy of skin at low power. It has that, what we call a cookie cutter appearance. And there's a little bit of fat around the eccrine glands here, but you can see that the collagen looks really abnormal. There's has a kind of smudgy pink appearance, and there are, especially here, you can see decreased spaces between the collagen fibers. This came in as real morphia, and I just thought it was a really nice example of it. You often have a lymphoplasmacytic infiltrate in morphia around the vessels. In the superficial and deep dermis, you can have eosinophils as well. It's hard, I think that the slide is a little bit fuzzy to show you the plasma cells here, but they're a nice clue to morphia. Sorry. So here's that really nice pink smudgy appearance of the collagen and the cookie cutter at low power. So this is almost a low power diagnosis. Next case. This was an annular lesion on the temple of an older woman. And you can see at low power here. There's a little bit of action here at the dermal epidermal junction. There's a little bit of vacuolar change, maybe a necrotic keratinocyte, some lymphocytes. They're these dark blue cells with not much cytoplasm, or vacuolar change. Very subtle, really, though. And then we have this kind of smudgy pink basement membrane here. We also these don't look like normal basal cells. They're kind of large, and so we call this a squamotized basal layer because they look more like the squamous cells of the epidermis rather than the smaller blue basaloid layer. And then in the dermis, we have a superficial and deep. It's perivascular and perifollicular infiltrate. Here are more of these changes we saw at the DE junction, even more prominent in the follicles. Here we've got necrotic keratinocytes, or follicular epithelial cells. This kind of bubbly vacuolar change. So we've got an interface dermatitis here, also on the follicles. Some of you are guessed the diagnosis already. And then we look at the infiltrate. It's mostly lymphocytes, maybe a few histiocytes, maybe some plasma cells. Are not kind of jumping out at me right now. But no eosinophils, no neutrophils. So I thought annular lesion, interface, superficial and deep, centered on the follicles. This is probably lupus. And I just wanted to show you the mucin stain here. Now you have to be careful. The mucin stain will pick up solar elastic fiber. So you have to look at your H&E and correlate it with your mucin stain. And this is really beautiful interstitial mucin deposition. If we go back up to the H&E, you can see there is some solar elastosis, but a little bit deeper. Let's see, there should be, here, yeah. Here we've got that kind of stringier, more delicate, almost lace-like bluish material. That's the mucin. And then for fun, here's the CD23 immunostain. CD123 is an antibody that stains plasmacytoid dendritic cells in the dermis. And these are cells that produce the interferons, which are crucial to the initiation of inflammation and autoimmune disease that you see in, the inflammation that you see in skin infections and tumors, but also in autoimmune disease. In my experience, and so the Yale group, about 10 years ago, published this finding that you could find large clusters of CD123 positive cells in collagen vascular disease, and that would help distinguish between other inflammatory processes in the skin. In my experience, not all lupus has clusters of CD123 positive cells. But when they're there, it's really nice to help out with your diagnosis of lupus. But it is a little bit controversial. Different dermatopathologists will tell you different things about CD123. I have found it helpful in cases where I suspect lupus, but the changes at the dermal epidermal junction aren't the greatest. Also in tumid lupus, it can also be quite helpful when you really have nothing happening at the DEJ. Okay, last case. This is a fun one. I don't know what the clinical was. Oh, I remember now. This was a case that came in as rule out autoimmune or immunobolus disease, excuse me. And it came with the DIF. And here's the H&E that came with the DIF. And you can see we've got maybe some hyperkeratosis, a little bit of maybe parakeratosis, very little inflammation here, some melanophages, a few lymphocytes. And then as we go through the stratum corneum, what is this bluish material here? You can see these are the spaghetti and meatballs of Tinea versicolor. So here we've got the hyphae and here the yeast. So we call that the spaghetti and meatballs, these basophilic yeast and hyphae in the stratum corneum. So Tinea versicolor is not really a true tinea. It's also called pityriasis versicolor. It's caused by the mycelial growth of the fungus in the genus Malassezia, and it's, as I said, not a true dermatophyte. These don't grow well in cultures, so a KOH prep or biopsy is required for the diagnosis in general. These can be highlighted by PAS stain, just like dermatophyte, and you can see here even better the hyphae, and let's look around for some of the yeast. There we go. The yeast induce enlarged melanosomes or pigment granules within basilar melanocytes in the brown type part of the pityriasis versicolor. So when you go to make the diagnosis, you want to take the scrapings from the hyperpigmented areas because you'll get more yeast in those areas. All right. So that is it for today. Hope you've enjoyed it. I thought there were some great cases that I got to show you, and we'll see you next week.